Welcome everyone to What is Black? I'm your host, Dr. Jacqueline Duget. I'm so excited to bring this very special episode. It's a crossover episode with my colleagues from Healthy Homes with the Hippocratic Hosts and Flesh and Bold. So I'm joined with my fellow colleagues, health professionals that are experts in their field, and we're going to touch on a very current and important topic, COVID-19 vaccine in communities of color. So let's get started with the conversation. Hello and welcome to a special crossover episode of What is Black? I'm co-hosting with my colleagues from Health and Home with the Hippocratic Hosts and also Flesh and Bold. I'm your host of What is Black podcast, Jacqueline Duget, and I will have my other co-hosts introduce themselves.
I'm Lonray Falusi, co-host of Health and Home with the Hippocratic Hosts.
I'm Lisa Verghese-Kroll, co-host of Health and Home with the Hippocratic Hosts.
Hi, I'm Nevin Hurd. I'm a co-host of Flesh and Bold.
So today we're going to talk about COVID-19 vaccination with special guests, Dr. Lauren A. Smith and Dr. Letitia Dzirasa. Dr. Smith is the Chief Health Equity and Strategy Officer for the CDC Foundation, and Dr. Dzirasa is the Commissioner of Health for the Baltimore City Health Department. So just for some background, COVID-19, as we all know, has disproportionately impacted communities of color with increased numbers of death and illness in both children and adults. Many of these disparities are attributed to the effects of systemic racism that's manifested in environmental, housing, health, and economic policies that then lead to these higher percentages of parents of color working as frontline or essential workers, overcrowded housing, and of course, decreased access to health care. In addition, there is a long history of distrust in the medical system, such as the Tuskegee experiment, even going back to times of slavery, I think that's really where some of the roots of the distrust of the healthcare system may have started in the United States. Also underfunding of health programs for Native Americans and historic feelings of discrimination by the healthcare system. We also have some child data from the COVID Kid Project. The purpose of that project, which stands for Coronavirus in Kids, Tracking and Education Project, their purpose is to monitor and compile epidemiologic surveillance data on COVID-19 in kids and teens in the United States. So as of September 2020, according to their data, Black and Hispanic youth made up more than 50% of child deaths due to COVID-19. Just for some additional data, compared to non-Hispanic white children, Asian and Pacific Islander children are 2.1 times more likely to die from COVID-19. Hispanic children are 4.7 times more likely to die from COVID-19. Black children are 5.3 times more likely to die from COVID-19. And American Indian and Alaskan Native children are 7.6 times more likely to die from COVID-19 compared to non-Hispanic white children.
So we want to welcome our guests and thank them for joining us today to discuss this important topic. So thank you for joining us, Dr. Smith and Dr. Dzirasa.
Thank you for having me.
Yeah, thank you.
How are you both doing today in the midst of all of this?
Well, for me, today is a very exciting day. I'm feeling hopeful and looking forward, but also thinking very seriously about what we have been experiencing so that we can learn from that as we do to go forward.
Yeah, I share in Dr. Smith's excitement. I'm at the local health department, so in the midst of doing vaccine rollout. So I'm also tired, but I am excited too.
Well, we're gonna get started by discussing the issues surrounding access to the COVID-19 vaccine. As Lonray mentioned, health equity and inequities are one obstacle, and distrust of the healthcare system in communities of color is another. So how are each of your agencies working to address health equity in terms of access to and communication about the COVID-19 vaccine?
Okay, I think those are great questions. So I'll start first with access. When we developed our prioritization matrix in alignment with the CDC's recommendations, we were very aware that access would be a challenge for certain individuals throughout our community. We're thinking of people with poor mobility or individuals who rely on public transit, older adults. We designed our prioritization schema with all of that in mind. And so we've been conscious of that even as we're setting up our pods. We recently transitioned to a pod in the city that is accessible by transit. Again, really focusing on how do we make this accessible. We've also taken a multi-pronged approach. So we recognize that there's going to be the place for the mass vaccination pods. We also recognize that individuals are going to go to their trusted medical home if it's a federally qualified health center. And so how do we work with our local FQHCs to ensure that the right individuals, those that may be older, those that have a trusted medical provider that they can go to, get there. We help a lot with that kind of that care coordination and outreach. Likewise, we're developing mobile vaccine strategy. So working with our healthcare partners, we would develop this mobile team that we would deploy. And we did this in the spring. We've done this around testing. We did this around infection control needs at long-term care facilities, but working with healthcare partners to really go into senior housing sites, for example, that will be one of the populations, but going into senior housing sites, based on relationships and partnerships that we've already established through the flu vaccine work that we did in the summer and fall, to provide that vaccine on site. So that's how we're ensuring access is equitable in terms of, how we're approaching vaccine dissemination. Messaging, we've been very specific and focused on working with community groups as well as the local community to understand, what do you want to see in messaging? Do you want to see individuals who look like you? Is it important that public figures get it? So I think we're exploring all sorts of avenues, whether it's social media, knowing that we're going to need to use all of those in order to get the message across to many different people.
And that's, really wonderful to hear. And I'm really glad that you went first, because our role at the CDC Foundation really is to support and partner with state, local, tribal, territorial public health departments who want to deploy their resources, just as Dr. Dzirasa was talking about. So we have supported both surge staff in multiple jurisdictions across the country and territories to be able to do the kinds of activities that you were saying. Unfortunately, and I'm sure, Letitia, this will resonate with you, many public health departments at all levels have been chronically underfunded and have suffered significant disinvestment. So they weren't in a position to respond to this crisis as they want to and know how to do, but they didn't have the staff to do it. So the CDC Foundation has put more than 900 staff across the country, epidemiologists, contact tracers, laboratory scientists, analysts, statisticians, all of the kinds of skill sets that a vibrant public health department needs. We've been able to support that surge staffing in a modest way across the country. So partnering with public health across the country is one way. The other is through partnering with community-based organizations. You just heard, and I think I have to plus one, the idea that people want to get information from and through organizations, messengers, folks that they know that just didn't arrive in their neighborhoods like 5 minutes ago to tell them to do something, but people they've been seeing who they know have their best interests at heart and who are, really there to engage and partner with them. So we've been working closely with partners, both national organizations that have local affiliates or branches, as well as individual organizations across the country to do precisely the kind of outreach and connecting that community-based organizations are, really poised and situated to do.
So thank you so much, Dr. Smith and Dr. Dzirasa. You all had, really highlighted some strategies, to communicate to various communities, different populations within our communities. But I was wondering if you could talk a little bit more about specifically outreach to families of color, and also maybe given an opportunity to really kind of share, some of the terminology that was brought up, right? We are public health, medical field, right? We tend to talk a lot about, the different systems that exist. But I think, even establishing that trust and strategies, I think it would be helpful for listeners to really understand, what an FQHC is, what is surge capacity, and also if you could share some of that information.
Sure. And I'm glad you are calling attention to it, and I'll do my best to avoid all of the shortcuts and acronyms that we're, so used so easily. So when I said surge capacity, I mean additional staff for local and state public health departments to be able to do basic key public health activities and tasks that are required during a pandemic response. So by surge, it's like the surge in need needs to be met by a related or equivalent surge in capacity and availability of people to do the work. So when I said surge, that's what I meant.
And I would say, I guess, just adding on, I think the question was also related to reaching out to communities of color. One of the things that we started early on in the pandemic were town halls. And we use a couple different types of platforms. So we certainly have done kind of the Facebook Live streaming town hall, maybe for the millennial, the younger population. It would usually feature me and a co-host that was typically a community leader or faith-based leader. And then we've also done telephonic town halls. And that usually would get our older adults. So a lot of our older adults would use the telephone town hall as a way to call in. And we've continued to do the same thing around the COVID vaccine, is again, the kind of the live online platform, but also we'll do a telephonic town hall related to the COVID vaccine. We'll do a series of those for our older adults.
Yeah, and just to add on to that, one of the things that we've been doing at the foundation is through partnering with coalitions like the Black Coalition, against COVID, as an example of health professionals and health providers. There have been a number of virtual town halls, like Dr. Dzirasa is talking about, that we've participated in. I've also connected with specific health systems and groups of health providers, because we know that those providers of color are going to be the ones that are really going to be on the front line of having the conversations with folks who may be interested in getting a vaccine, and those with folks who may be hesitant or have concerns or questions about it. So we've been looking to reach to providers who serve communities of color to be able to answer their questions, provide them with information and messaging, and really sort of brainstorm with them about connecting with people to be able to address the very real and reasons that people may be hesitant to receive the vaccine.
So you've both talked a bit about partnerships, which I think we all agree is key. Can you talk a little bit more about that, and even going forward, what additional strategies are needed to overcome the mistrust of the vaccination by many people of color? What different sectors can do? What can we do in the healthcare sector, or even more broadly to work on that, to try to help people overcome that mistrust?
Mm-hmm. I would just
start off by saying that
I too am a pediatrician, like Dr. Dzirasa, and practiced for a couple decades. And a key aspect in connecting with folks to be able to address their concerns is to acknowledge the validity of their concerns and to listen with empathy and openness, so that you can hear what's at the root of what their concerns are, so that then you can begin to address it and be able to not counter, but sort of respond to some of the myths and bad information that people have, not knowing that in fact, what they're concerned about is false, or that, they've been receiving, incomplete or sometimes just, inaccurate or untrue information. So acknowledging that their feelings are reasonable. You started at the top of the podcast, listing a lot of the reasons why people might have some concerns. So acknowledging that and reckoning with that. And then providing facts. I think providing facts in a objective way, from a place of caring, from a place of wanting to protect you and your family and your loved ones, I think is really important. And then the last thing I would say is to not inadvertently reinforce the misinformation and false information that folks have been inundated with, unfortunately. So to be always speaking from facts, from truth, and from that place of empathy and understanding.
Yeah, I completely agree with Dr. Smith. I mean, I think certainly one of the things that we've tried to do and have done since the beginning when we're messaging to the public is being as transparent as possible, right? And acknowledging what we don't know, right? So in addition to, acknowledging that the fears and the concerns that people have are grounded in some historical truths, how do we also say, this is still a novel coronavirus. This is a new vaccine. There are things that we know right now, and there are things that we don't know. But as we learn them, we will be honest and we will be transparent about what we're learning.
Yes, that commitment to transparency and being clear about what are things we know. As an example, we know that this vaccine cannot give you COVID. So we know that, and we can talk about why that is. We will be following very carefully is how things go, years from now. We don't know that, but that transparency and commitment to come back to be able to talk about whatever we find at a regular cadence so that people aren't wondering like if there's some shoe that hasn't dropped, I think is really important. I think one other thing I was going to mention, and I wonder if Dr. Dzirasa, how you're focusing on this or how you're finding it, is around describing how vaccines work in general, but how this specific vaccine works because it is different than other vaccines that we as pediatricians would routinely do or provide for our patients. And so I think, many Americans really don't have any understanding of how vaccines work in general, let alone how this particular unique vaccine works. So I think, part of what we have to do is explain that in very layman's terms so that, people can really take in the information so that they're prepared to make an informed choice. But if people don't even understand how vaccinations are supposed to work, then they're not able to make an informed choice. So they're more susceptible to all of the myths and misinformation that might be floating around.
And during our town halls, we do take time to review the mechanism by which the vaccine works. We've also spent a little bit of time on clinical trials because that question comes up a lot. The speed with which this was, created is, how did it happen so quickly? I think, people also, I think if you're in medicine, you kind of understand what a clinical trial is, but the layperson doesn't understand how things move through a clinical trial and doesn't understand that, we typically in a clinical trial, wouldn't necessarily start with children and pregnant women. And so, that's why there's no safety data around that particular group at this point. So we've spent time talking about that as well as the differences between the vaccines that have been approved. So we do spend some time reviewing that as well.
So I think that might be a good time to really kind of talk a little bit more about the vaccine, because I know because I even polled my family and friends to try to figure out like what are the burning questions that they have, and so we can talk a little bit more about that so that our listeners have a better understanding of, like you said, what the vaccine is and how the vaccine works.
Yeah, I think historically, we know that vaccines have taken years to achieve approval and then become widely available. So can you expound a little bit on that and talk to us about how it was that the COVID-19 vaccine was made so quickly and whether that should be a cause for concern?
One thing I would say is that the messenger RNA, which is the kind of vaccine that this is, because of the type of vaccine and the way it's produced, it was able to be produced more quickly just because of not having to grow up the virus and just the mechanisms of how you make the vaccine allowed it to be produced more quickly and to be able to be ramped up. But one thing that I emphasize in talking about this is we've been working with, or scientists have known about messenger RNA, again, which is this type of vaccine for a number of years. And there's been efforts at developing vaccine for a number of years. So this isn't the first time this has come to pass. But fortunately, science has advanced since people were trying to use this for Zika and Ebola and other kinds of infectious diseases, so that at this point, they were able to really move more quickly. The other thing is that they've also, in the trials, were able to do things in parallel, whereas in more typical times, they have to do things one after another, which takes longer to do. But they took the steps to try to do things in parallel. But Dr. Dzirasa, I'm sure there's other things you would add to.
No, I mean, I think you hit the nail on the head. I mean, what we've kind of talked about in some of our town halls is what does it mean to be a messenger RNA, right? We get the question a lot, is this going to change my DNA? And we make very clear that that's not how messenger RNA vaccines work. And we talk about antibodies, and so messenger RNA coming in to produce the spike protein, which goes on your cells, does not affect your DNA, but does trigger your body to produce antibodies to fight off coronavirus if it were to appear. But we make very clear you're not being injected with the virus, because we do get that question a lot.
Mm-hmm. And I think what I've heard anecdotally is it made a difference, right? That one of the prime scientists that developed the vaccine was a Black woman, or is a Black woman. And I think our representation and what I've seen, in many of your talks about the vaccine is that, again, utilizing doctors of color that are trustworthy, by many patients has also been, I think, very vital, right, in really getting that message out about the vaccine. So I'm saying all this to say that, there's still questions people have about the vaccine, but hopefully I think that provides some legitimacy, right, in understanding that, this was a well thought out vaccine, and we utilized the technology, right, and the funding that sort of went into and really helping the manufacturers develop the vaccine, which I'm so happy that they have. And I've gotten vaccinated. And I don't know if you all could talk a little bit about, like some nuts and bolts about the vaccine, side effects of the vaccine, if you've received the vaccine yourself, to also talk a little bit more about that.
Sure. So I received the vaccine. I guess it's been 2 weeks ago now. So I am a public health professional and also have been trying to help at our vaccine pods when I can find the time. So I did get vaccinated. So I've gotten my first dose so far. I experienced just a little bit of soreness in my arm and a headache. And the headache actually went away when I took, Tylenol. So that was a relatively mild side effect. Same thing, the soreness in my arm went away after about 48 hours. And this is a common side effect. So what we know of the COVID vaccines is that you can have, pain, redness, soreness of the arm. And this is similar to what we see with flu vaccine as well. So some individuals also experience the same thing with flu vaccine. Additionally, you can have, like I said, the headache that I had. Some people have muscle pain, joint pain, fatigue, fever, and this is also more commonly reported after the second dose. So I haven't gotten my second dose yet, so I'm not sure what the side effects will be. But again, milder symptoms, and if I do have side effects, we'll take Tylenol or Motrin to combat those.
And the thing I think to also make sure that listeners understand is the side effects that Dr. Dzirasa just talked about are also a signal that the body is in fact responding to the vaccine and preparing for the next time it's going to be ready. So all of those things that she described are a way that our body responds to, an infection threat. And so it's not that it's good that she experienced them, but it is a sign that her body was responding to the vaccine.
So some other questions that, that came up, again, from my mini poll of family, right? So they wanted to know, is the vaccine, we've heard a lot in the news about the mutated strains of the virus. And so I know a lot of people had questions about that and how frequently the vaccine would have to be administered. Would it be similar to the flu vaccine? So I was wondering if you could talk a little bit about that as well.
Sure. So I think based on what we know right now, and again, using that based on what we know right now, it does appear that it will be effective against the mutations. But again, that's based on information we have now. I think we're still determining if this will be an annual thing similar to the flu vaccine. So I think we'll continue to study again those individuals that were in the initial trials. But I think that's something we don't know yet. Will it be annual versus will it be one and you're fine?
One other thing just to mention about the trials that I bet came up in some of your questions, and I was going to mention this, which is, people are asking or wondering, were people of color included? Were people who had chronic illness or underlying conditions included? Because a lot of people will want to know, well, I have diabetes, I have heart disease or hypertension. Is it okay for me to take it? And I think it is important, and I'm sure that's happening in Baltimore as you're talking about that, right? That you can say, hey, there were, people of color in the trials. There were people with chronic illness in the trials. So there was a significant, I think, effort made to be sure that the clinical trials were representative.
And then just following up a little bit more, when you talk about the clinical trials, you can talk a little bit more about, I guess, the rollout of the vaccine, right? So right now, I know in many cities, many states, that healthcare providers are really like the first on the list, and assisted, individuals might in nursing homes. But, there've been questions about, when will children get the vaccine, and how that plays also with the clinical trial in terms of, who gets the vaccine based on those trials as well.
Yeah, so I think, as of right now, there was one vaccine, the Pfizer, that was in individuals 16 and above, and the other, Moderna, was 18 and above. I know that they're beginning clinical trials in children as young as 12, but I don't know that we have that information on timeline. So I think it kind of brings up a good point, right? And that it will be extremely important for parents and grandparents then to get the vaccine to help with developing that herd immunity that we're looking to achieve. But, I think that, again, what I would reassure people is that it's not abnormal that children weren't included in those initial clinical trials, and we'll just need more time.
Right. And I just want to underscore that recommendation for adults to get vaccinated, when, their turns come up. We talk about in pediatrics this concept of cocooning. So a lot of times, infants and young children, when they can't get a certain vaccine, we really emphasize and encourage the adults around them to get the vaccine. So they create a cocoon of protection around that infant or child. And so I think this would fall into that category also.
Then we have some questions thinking about sort of after someone gets the vaccine, or looking, forward over the next several months. So if people receive the vaccine, do they still need to wear a mask, or should they feel that they are now protected and don't need to wear masks anymore?
Yeah, so I threw out a word. I know we were supposed to be avoiding certain terms, but I threw out that word, herd immunity. And I threw that out there because, the part of the vaccine is to help us, obviously, to eliminate coronavirus. But we will need to achieve a certain amount of immunity in our population for us to get to that point, probably somewhere between 60 to 80%. And so we know that, obviously, the vaccine does help with, reducing severity of illness if you are exposed to COVID, and reducing your chances of getting the virus. But it, there is still a lot of virus circulating. We've not yet achieved the herd immunity, so it will be extremely important that even once you're vaccinated, until we get to that point, that you still wear your mask for protection.
And it's also, just to add on to that, one of the things we do know about the vaccines is that, as Dr. Dzirasa just mentioned, it protects you from getting sick with the virus. We're still not 100% sure yet whether or not after the vaccine, I may have the virus sort of in my body, but not getting sick from it. And if that's the case, then I could, through no fault of my own and, unknowingly spread that virus, even though I'm not getting sick because the vaccine has protected me. So one of the things that we, at the CDC Foundation, the CDC is, continuing to sort of emphasize is those, what we call mitigation measures, those measures that are used to control and decrease spread. still need to be in effect as we continue to move through the vaccination process, just as Dr. Dzirasa was talking about. So that's wearing your mask, washing your hands, being, the social spacing and distancing. So you're, not inside and crowded. You're not inside in crowded, conditions, et cetera.
And for right now, both of the vaccines that are on the market, Pfizer and Moderna, require a 2-dose series. So after the first dose, how well protected is someone? Do they absolutely have to get that second dose? And once they do get the second dose, how soon is the vaccine effective once they're done with the 2-dose series?
Yeah, so I think after the first dose, I've read about 80% effective in terms of protecting you. But then the second dose, obviously, it's more of that 94 to 95%. So even more protected. Again, typically it might take, about 2 weeks or so for your body to begin producing the antibodies. And that would be after the first and the second vaccine. So it's still very critical that you get that second dose. Again, when we think about achieving, herd immunity and having the majority of the population covered, getting that 95%, 94 to 95% efficacy will be key to that.
Great. I think that's a really important point. So you do hear people sort of saying, the partial coverage, partial immunity is not enough. And I think you've underscored that point, that it is really critical for people to get both doses of the vaccine. And you talked earlier about mutations that are occurring right now with the virus. Do you anticipate that in the future we might have a different vaccine because of these mutations that are happening? And with that, how often do mutations occur with viruses?
Yeah, I think the one thing I would probably underscore is that mutations in viruses are normal. So this is not, again, abnormal because it's coronavirus. And certainly we've heard reports of increased transmission or transmissibility in theory when you're looking at the data. But again, this is not abnormal. I think it will all depend on how it mutates. I think we just don't have enough information to say at this time.
Right. And viruses can behave differently. So people are used to the idea that they get a flu vaccine every year because the viruses that cause influenza or cause the flu symptoms change or modulate over time. So that's why they need to make a new vaccine every year. Whereas there are other viruses that you get immunized against that you don't have to do that because they don't show that same likelihood of changing or evolving. So like mumps, for example, or rubella vaccine.
As we talk about COVID-19 and the way we started this conversation, I think it has really kind of brought the idea of racial disparities also to the forefront. And I guess I'm curious to hear from you, both of you, when we talk about health equity. I think it's important that we consider systems of power and oppression. I'm curious if you've seen racism affect the delivery of vaccines, or if either of your organizations have prepared or considered how racism might seep in to how vaccines are delivered in that aspect.
Well, I think one of the things that you all mentioned at the beginning of the podcast is that we know that structural racism increases the exposure to this virus. It increases the likelihood that you will get sick. And if you get sick, that you'll get really sick, and the likelihood that you would die from this virus. And that we know that, and we know the connection points for why that is. And you went through many of them in terms of the kinds of occupations that people of color have, where they live, how congested or how dense their living situations are, whether or not they can stay home from their jobs. Do they have work flexibility that will allow that? Or are they going to miss their wages? And so they are more likely to have to go to work when they're sick, or more likely to have to ride public transportation, even if they would prefer not to. So all of the things that we know about structural racism in terms of where people live, where they work, what put them at risk in the first place, that is why we are seeing the pattern. This is not unpredictable. Those of us in public health who do this work, as this was coming up, we knew that this was how it was going to play out, because we knew what the forces were that were going to drive it to this not conclusion, but to drive it to this pattern of having such a disproportionate impact. I think those same forces are at play now. And so we have to actively undo them or actively be aware of them. And all of the things that Dr. Dzirasa just talked about in terms of how she was thinking about where the locations were, how she was thinking about getting over transportation barriers around time of day. People who work and don't have work flexibility can't come 9 to 5 because they can't get off of work, or, so there's so much of that if you don't take that into account, then the structural racism that led to that will undermine our opportunities to get, people of color vaccinated. So it takes a conscious and intentional effort, being aware of all those structural barriers and doing what it takes to remove them to be able to sort of build equity in. And I think that, just kudos to Dr. Dzirasa and her colleagues, because, everything she laid out are the exact examples of doing that in a conscious, intentional way.
Awesome. Thank you for that. And I'm curious, along with that, and knowing how communities of color have been disproportionately affected by COVID, and especially hearing the discussions of how certain populations were prioritized with the vaccine. I'm curious, have communities of color, have there been initiatives to prioritize vaccine delivery to them as well?
So at least at the local level, again, it's much of what I mentioned earlier that Dr. Smith just said, right? We have the advantage of knowing and understanding our community. And so we've really tried to devise strategies that will reach those that are hardest to reach. So the mobile strategy, again, recognizing, our older adults, many of our older adults, Black adults in senior housing sites who don't have mobility or the ability to they can't go to a mass vaccination site. That would be very challenging. And so we've been intentional about how we've designed our strategy for dissemination around that as we're thinking about that. And we'll work again with hospital partners to look regionally, right? So we're very fortunate in Baltimore City to have 11 acute care hospitals, and they want to support. They want to partner with us. We know the community well, and we work with community-based organizations often. They have the clinical providers. And so we're looking to partner with them and again, take kind of a regional approach based on what area of the city the hospital might be in, what population are they well versed in. And so we've really been intentional in how we've kind of planned out our strategy and our outreach and communication to minority populations. Our Latinx population here in Baltimore City has been particularly hard hit, as well as our older adults and Black adults.
Thank you so much, because I think you pointed with your answer, you also pointed out the idea of the intersection of identities and systems at play. So not just communities of color, but the intersection between communities of color and aging adults. And Dr. Smith, you mentioned socioeconomic status, the people who aren't able to call off work because of that. And I think that's an important detail not to miss. And so my last question, especially after hearing all the work that you're doing, Dr. Dzirasa and Dr. Smith as well, is has COVID-19, especially from how intentional you've had to be to reach these communities, has it inspired your agencies to consider and implement any other type of structural changes that you think bring about greater health equity moving forward?
Yeah, at least at the local level, I am looking to create an Office of Policy and Advocacy. So we have a legislative director, we have a director of external affairs, but I'm really looking to create an office that is really devoted to how do we promote health equity here in the city, but also at the state level and even at the federal level, right? Understanding that, when I think about kind of the local health department and our interactions with, other city agencies and city government, we should be at the table for every piece of legislation. We should be there, indicating, providing a health impact assessment for a particular piece of legislation. And so really trying to position us as a local health department to be that chief health strategist for the city and for policies as they're being developed. So I am looking to create that office in the coming months in my spare time.
And, you know, part of my role specifically, my role is a new role with the CDC Foundation, and is to develop an equity strategy for the entire organization and to ensure that it is integrated and interspersed throughout all of the work that we're doing. There's been certainly elements of it already, and I think it's, you know, as I said, we can be even more intentional about doing that, and that's the work that I'm leading.
That's great. Thank you so much, both of you. And I think, you know, in terms of kind of our final thoughts, the question that probably all of us in healthcare receive the most is, when will life return to normal? You know, and we know that we will not return to our previous normal, and that our previous normal is not necessarily something that was really something to aspire to. But I think what people really mean is, you know, when will quarantine and distance learning and masking and closed borders and that kind of thing, when will they be a thing of the past? So what would you both say to that? And what are your other final thoughts?
So, I mean, at least at the local level and in the city, we still have a number of restrictions in place, and obviously have our mask order in place. You know, we have tried, you know, to bring students back to school safely, and are working now to vaccinate our educators and school staff so that we can help support that. We recognize how important it is for our children to also be in school learning, but we're you know, going to be vaccinating well throughout the rest of this year, I think, when we're, you know, again, setting such a lofty target of really 60 to 80% of the population being vaccinated. So I think we've still got at least through 2021 where we're wearing masks and maintaining some social distancing.
Yeah, I would agree. I know that it's hard to hear, and people would prefer to hear something that would sound better. But I think one of the things that Dr. Dzirasa talked about is a commitment to transparency and a commitment to honesty. And I think helping people manage their expectations so that they can prepare themselves for, you know, what's likely to come and think about how they're going to get through it together, I think is really important. And so I think it's for a leader like Dr. Dzirasa to say, you know, this is what I'm expecting, and you know, this is how I'm going to be with you to help you prepare and sort of get through this together. But I think we don't serve people well to tell them something that we know is not likely to be true, even if they would prefer to hear that.
So we want to thank you so much for joining us today, Dr. Smith and Dr. Dzirasa. And this was, I think, a very important conversation, and I think a very, very timely and very helpful conversation. So thank you again.
Thank you. Thank you for having me.
This was a very important conversation. And like I said, it's so relevant to the times. And my goal for this season of the podcast is really talking about how do we move issues of equity, moving issues of assuring the health and well-being of Black communities, communities of color. And one vital important area is this era of COVID-19. We're going to get through this through vaccinations with an equity lens so that all people, especially communities of color, have access to the vaccine and have access to important information. So I definitely want to, again, thank our wonderful guests, Dr. Lauren A. Smith and also Dr. Letitia Dzirasa. They are excellent personified, and I feel so confident knowing that they're in their positions within public health, within healthcare, to really advocate for equity. And again, I want to thank my co-host for this Powerhouse crossover episode, the hosts of Healthy Homes with Hippocratic Hosts, Dr. Lanre Faluse and Dr. Lisa Varghese Kroll. Also, I'd like to thank the co-hosts of Flesh and Bold, Dr. Nevin Hurd, and also Dr. Nia Hurd Garris, his sister and co-host of Flesh and Bold, who also helped contribute to this episode. And please subscribe and listen to their podcast. Again, the Healthy Homes with Hippocratic Hosts and also Flesh and Bold. Please follow them on social media. Subscribe, listen, rate, and share their podcast. And again, thank you so much for joining us today. I'll put links to additional information about the coronavirus vaccine and additional information on the website at whatisblack.co in our show notes. Well, that's all for today's episode. Thanks for listening. I'm grateful for your support and community. What is Black is hosted by Dr. Jacqueline Dugay. Music and editing by Manny Simone. Make sure you subscribe to the podcast wherever you listen to podcasts so you never miss an episode. And please subscribe to our newsletter so you can find out what's going on this upcoming season. We're going to also be launching a new book club initiative, and more information will be shared in our newsletter and also on our social media platforms. So please follow us at What is Black, WHATISBLK, and also subscribe to our newsletter on our website at whatisblack.co. Until next time.